We are going to have our own professor, Professor Kokwaro. But before I do that, maybe I wish to introduce myself. I am Professor Margaret Oluka. I'm still at the School of Pharmacy, University of Nairobi. They're about to exit. And before I continue, I wish to acknowledge the presence of my classmate, the one we were sitting with, Dr. Wilberforce Omutanyi Wanyanga. Yeah, further to that, in this same room, I have my mentors who have made sure I've walked this journey up to where I am. From after undergraduate, they saw me through the master's program up to the PhD program, led by our own emeritus Professor Gwantai, Professor Kibwage, and Professor Kokwaro. They have made me who I am today. They walked me that journey. Thank you so very much for your best mentoring that you gave me. So our next speaker is Professor Gilbert Kokwaro from Strathmore University. And I wish to invite him to come and take the podium. He will introduce himself because he's a most distinguished and eminent professor. Welcome, Professor.
Thank you, Professor Luca. Good afternoon, all of us. Good afternoon. Where are the undergraduates? There are people in the diaspora. Good afternoon, good morning, wherever you are. This is Kokwaro speaking to you. Now, for those who don't know me, let me introduce myself very, very briefly, especially for the youngsters. I'm Kokwaro. I left University of Nairobi 2014 to go to Strathmore. And what I'm going to present is a different lens at looking at health system. Otherwise, I'm a clinical pharmacologist by training. That is from postdoctoral level onward. I'm interested in severe malaria. I've done that for 40 years. I'm addressing the youngsters, and there's a reason here. Right now, I have grants on malaria. That tells you about the need to know where you want to go and what you want to focus on. At Strathmore, I head the Institute of Healthcare Management. I train several pharmacists. So ours is not to train you on technical, that one you've got, but to manage health institutions. I run an institute of, we have now got right now 34 PhD students. We are running the only PhD in healthcare management, which is doing pretty well. About 200 master students on healthcare management. And we run a healthy grant portfolio. Right now, I think we have $10 million US. That's the thing. So we are about 6, but we contribute the majority of research income there. Just also to show you, this is not self-glorification. Remember, I'm a pharmacist. So I'm trying to tell you that. But I was paying tribute to Professor Gwantai, Professor Kibwage, and my colleagues there. Don't call us old people. I told her, just say we are early. It gives it. We are still going strong. But the reason why we are here, the reason why you see these people here, when we were undergraduates, things were bare, but we were focused on what we wanted to do. That's critical. We were focused. If you want to remain relevant, you need to be focused on what you want to do. We may not have changed things, but I think we have made some important contributions to this country. As the last thing on my introduction, which I don't want to bore you with, is if you remember President Uhuru, the immediate former president, set up a committee or a panel to try and develop a framework for universal health coverage. I was the chair. I don't know whether you are too young to know. I was the chair. I'm not very intimidating, but I'm telling you that we have contributed various aspects of health. Yeah. So today, I don't have enough time, unfortunately, but I wanted to take you through looking at health through the health system lens, and then looking through how you can go about the challenges of health. For the purposes of, or for the purposes of this presentation, you can bear with me, senior people. I'll try to explain to them certain key things for them to understand the rest of them. Margaret, you can stop me when we. So this is the first part. If we have time, I'll go to the second. So this is it. The challenges of health system in sub-Saharan Africa in the context of 4Ds and climate change. I'll explain to you. The first D is, you can write, demographic transition. The second D is domestic financing transition. The third D is disease transition. The fourth D is donor transition. And that is where Trump comes in. These are now the things that as pharmacists we have to do, because this is the discussion. Okay? So, but let me, before we go to that, let me just quickly, supposed to be moving. Beautiful. For the benefit of the youngsters, I want to give you a definition of health. You may wonder, oh, why not? If you don't get it, the rest of the things then start getting a bit fun. Health and health system. And then I get functions of the health systems, objectives of the health system, and then health system structure and performance. And then I'll bring that with the next thing and say, what are the main problems, challenges of health, and why we are having some challenges, especially with the training that Prof ably summarized. All those have got an impact on the health. Okay. This definition is there, but most people brush it, but this is the key. So the WHO defines health as all, consisted of all organizations, people, whose primary intent is to promote, restore, and maintain health. From there, you can get the characteristics of health. That definition is rich and informed. So what are the characteristics from that one? It shows that the system is complex. Health systems is complex. The health system is open, and the health system is dynamic. That's the definition of health system. The definition of health is that state of complete physical, mental, and social well-being. Therefore, if someone asks you, there is no health without mental health. There's no health without mental health. I think that's really the whole thing. Okay? Now, if you combine those two definitions with the health system, we now start seeing where, and I'll show you where pharmacy comes in. Look at that sphere. Again, you can look at that. Look, health starts at the household. The answer, health starts at the household. Some decisions you make at the household have got profound implications as you get out. So there's the household, then there's the health sector, then there's the domestic sphere, and the rest of the world. The next slide makes it much, much easier. So at the household, that's where we deal with individual health issues, such as blood pressure, mental health. This is a narrow aspect. And then when you go to the health sector, then you go to the relationship between the health sector. And remember, I told you that the health system is complex. So there are different aspects of the health sector but there are also non-health sector that affect health. For example, education sector, agriculture, environment, and so forth. You now need to realize that health is not only complex within the health sector itself, but it also interacts with the health sector, the other sectors. The fact that it interacts with the other health sectors means that it is open. That is one aspect of openness. I hope I'm not going too fast. Okay? Okay. Let me now give you the other aspect of the health system being open. Look at those consecutive circles. It helps to explain the difference between disease outbreak, an epidemic, and a pandemic. Where are the undergraduates? You are one. Yeah. What is an outbreak? Any undergraduate? I know an outbreak is an outbreak, but that's not, it's not good. So an outbreak is a sudden surge in cases of a particular disease. If you don't deal with an outbreak, then it spreads other parts further away from where it then becomes an epidemic. If you don't deal with an epidemic, then it spreads even to different continents. Then it becomes a pandemic. And that explains something that happened in some market in China in 2020, 2022, ended up here. It's open system. So people move, okay? People move across border. So you can then see one of the futures, apart from the health sector interacting with the other sector, people also, and diseases also move. That is the characteristics of the openness. I hope it makes sense. Yeah? Okay. Okay. We said from the definition that it includes all those who deliver healthcare, public, private, formal, informal, regulated, non-regulated. Remember what Professor Kiwage said about traditional medicine. It means by the time people reach the actual formal, be sure they have passed through some places, whether they were waving guards or not, but they have. Those are the things we deal with. In fact, now in pharmacy, you know, they have taken certain concoctions. Yeah? That's the thing. All sectors. Again, it's good to have this as a background, because then by the time people reach there, we have done that. And then we have a role, and I'm sure we used to have our part of, you see, service to community, or packaging some messages to them. You need to put this into, okay? Then it also means that there is money flow across different, unofficial, and for us who are in out-of-pocket expenditure. In other words, where families are forced to dip into the family resources. It's still part of this definition. So this also includes activities, those that provide special inputs and healthcare processes. Let me skip that. I want to then take you the next step, the functions of the health system. Some of you may not have done that, but the health system has got 4 functions. Let's look at it. Stewardship, creation of resources, delivery of services, and financing. The next slide now is the critical one, because it is a small cartoon showing are the arrows coming from stewardship. Stewardship means oversight. And as I will show you later, one of the challenges of health in Kenya, in sub-Saharan Africa, anywhere, is stewardship. It's stewardship. I'll explain to you in some detail if I have time. But look, all the arrows, so stewardship here is one of the functions of the health system. And who are the people supposed to provide stewardship? Very, very quickly. Boards in hospital facilities, heads of departments, heads of programs, and so forth. It starts from the national up to the stewardship. And you can see that if you have good stewardship, you will have good health outcomes. If you have good stewardship, you have good health outcomes. So that is, okay. So it means providing oversight over other health things, functions of board, CEO, heads of the departments. So all of us here who are heads of departments, who are deans, who are VC, and who are running, we are supposed to provide stewardship. That's our main function. Okay? Let me go to creation of resources is another function. An organization, part of the stewardship is to make sure you facilitate creation of resources. Again, we have had cases where some of our institutions are struggling. It's the failure of stewardship, not on, at some particular level. That's really the main thing. And then provision of drugs and so on. Financing comes in. I'm trying to do this quickly because of time so that we don't go. Then we go to the next. What are the objectives of the health system? After the function of the health system, these are the objectives. Again, you can see objectives are now here. And this was improving health service, health of the population, responding to people's expectation, and making sure that those who are unable to pay for services have got financial protection. Those are the objectives. Again, these are just elaborations on this, which will not go into that because of time. Lastly, I want now go into the structure of the health system, a very simplified structure. Let's have a look at this structure. You see that the upper part of this slight orange, that is supposed to be where most of us should be. In other words, it represents people who are relatively healthy or have recovered. That is where we have health promotion, health, disease prevention, control, and rehabilitative health. Let me ask you a simple question. The lower one is, let me ask you a simple question. If you don't invest and you have fairly well-organized system waiting for people in the hospital, what will happen? The answer is it eventually will overwhelm the curative one. And therefore, the message is that we should put resources in promoting health at the same time so that we catch diseases early, surveillance and prevent diseases, and we don't overwhelm. This arrow represents a journey of someone who suddenly catches some becomes ill and comes down here. Hopefully the person will find proper diagnosis, treatment, and they go back. It doesn't happen, especially pregnant women and children under 5. So thus, our children and pregnant people, when they come here, they don't go back. Either because we have not invested enough in preventive curative, or here, lower down, or the whole system is collapsed. Again, we are familiar with this. This is just basic health symptom structure. Okay? Okay. Why should we invest in health? Health A healthy nation is a rich nation. In fact, this is the statement. See, health is a country's greatest wealth. That is the statement. Health is a country's greatest wealth. Those countries that have not invested adequately in health are struggling. And nobody can argue with that. So we people in health should always know that you are custodians of a major country's wealth, asset, which is wealth. So it builds on human capital, reduces poverty, and safeguards health and economic stability. So that's really the. Now, this is the slide that we'll go to. What are the factors that make optimal performance of health systems in sub-Saharan Africa? I've given you a hint. Good slides. There are only two. There are only two. Whether you are going to a conference, you don't need. You don't need. There are only two. The unique part is that there are two sides of the same coin. And that's where we disagree with some of our politicians. I think we are safe, Professor Bantoni, who are not politicians. There are only two. One side of the coin is insufficient funding. Insufficient funding. How do you know it is insufficient? There are two criteria. The allocation of funds for health, the Abuja Declaration, its promise 15%, and a percentage. If you invest, if you allocate less than 5% of a country's GDP, you're going to struggle. Where are we in Kenya? I think it's 1.28. In terms of Abuja, we are struggling between 7 and 8. So insufficient funding is not the only thing that the country invests in. It is the other side. Inefficient use of available resources. Source for health, action, and those kind. Should we start? Ask for more money for help, or do you address inefficiencies? Anyone here? Anyone? Yes. You address. You will not know the gap until you stop stealing. You will not. So, as a nationality, it's don't go down that way. Reduce yourself to a level of talking yes. You get it? It is too cheap. You need to deal with the inefficiencies in using available resources so you can know the deficit so that you will. And inefficient use of resources is in the broader sense. Simply getting people trained, you are not able to do is efficient use of available resources. Are we together? Yes. Forcing people to facilities that do not have the tools of the trade is inefficient use of available resources. Ordering very expensive medicines that then expire because you do not do a proper quantification is inefficient use of available resources. Are we together? So there are those two. And now the two. Now, that's the slide. I'm summarizing for you. Now, have a look for what I've said. Inefficient use of available resources and sufficient funding. What is the core of the problems of health in Africa? You don't need anybody else to tell you anything else. Let's say that someone in the pioneer class of pharmacy in 1970s have said no, and we are right. You get it well? Yeah, we were pharmacy, but we were taught well. This is. Now, then around that, look at the, sufficient time. Don't worry, I'll keep it time. Sufficient time. Now, I'll just use this slide now to elaborate. You see that? Now, have a look. See now, What are the compounding things? These are the things around. Around it now, you have disease transition. You have now added disease transition. So for Kenya, what's the disease transition? We are getting more cases of NCDs. Yes, in some facilities, 60% of the inpatient beds are occupied by people who have got one form or another of NCDs, non-communicable diseases. Disease transition. We are also getting new forms of infections, things that we thought had not been because of climate change or something like that. You see that? Now, we are saying that now you put that as just making this situation worse. Then we have demographic transition. Demographic transition is a time bomb for Kenya. It is actually estimated by 2050, 60% of Kenyans will be below 50 years of age. But it's nothing bad. The majority of those people do not have enough formal employment, and therefore they don't have any sort of insurance. Secondly, the youngsters also, based on this, do take risks. Therefore, their health is a challenge. Got it there. Large number unemployed, so no form of insurance, but also certain requirements. So that's the demographic shift. I've left out the elderly care in that's the difference. The profession is not. So demographic shift is comes from them. The third one is domestic finance transition. It level because we are not allowed that is what's called domestic transition. One where if you allow me the 4 minutes, I just some of them. It's called transition. Transition is this area transition from a low income country to a lower middle income country in 2015. What does that mean? Some of the donors who are funding some sectors of the some components of the health sector said we are no longer eligible for that kind of. That is what is called transition. Transition and HIV, malaria, and that those are transition as a final summarizing for transition is it can be organized and sometimes it can also to get them. You are donor dependent, and if there's donor concentration. Sorry, because of the time that I just want. What is donor dependency? Donor dependency is when Dr. Wanyanga lends me $1 and I cannot pay more than 25 cents back. Then I'm donor dependent. Where the ratio of external family to domestic is, you can put it in another, is greater than 0.25. If you cannot pay 25 cents out of $1, you're donor dependent. And Kenya has been donor dependent in those 4 sectors since 2001. You now see that. That's called donor dependency. It means you cannot fill the gap. Imagine I just told you it's so low. If you cannot pay, ideally you should be able to pay the dollar, isn't it? But we have published a paper where it said the dependency is set at 25 cents. We are not. And if we had time, I would have shown you. The areas most hit are fashion. Where our donor dependency index is rather than less than 0.25. Then HIV Donor dependency, our index is 0.6, should be less than 0.25. Area will just over 0.5. That is donor dependency. So when you are talking of this thing, you need to do that, and I've given you the cutoff 0.25. The other one, before I conclude, is called donor concentration. Less than 20% of donors contribute about 80% aid. Again, Kenya highly donor concentrated. Only it was US aid, okay? Then it was global 4. What it means that only a 4 donors, therefore, contribute the majority. It means that if one of them is out, you have a major hole. So there are two things. Yeah, donor concentration and donor dependency. How are we doing in both? Badly. Conclude. Badly. We are going to struggle to fill that particular gap. Going to struggle to fill that particular. Now, what will happen? You remember what is likely to happen is some of the gains that we had actually achieved are going to pass. And one example is an availability to ARVs. So what will happen in the community? So those people who had suppressed virus are now going to reach a level where they are starting to infect people. That's a practical one. I'm not frightening you. I'm giving you practical example. Immunization. If we are not going to do immunization, then I think we have a disaster in terms of our children. Sorry about that one, but I hope, Margaret, with those rather rash thing, you got a point. Let me summarize. Let me just summarize. One, health system is complex, it's open, it's dynamic. The current problems with the health system are two: insufficient funding, yeah, and inefficient use of available resources. Those two problems are worse by these 4 Ds, and then where I didn't have time. Around these 4 Ds, there's what is called climate change. So there are 4 Ds and a fifth one, climate change. Those ones are making it very deep. So you can ask me, give an example of what climate change. Sustained ambient temperature is associated with stillbirths, increased cases of stillbirths. And in fact, if you go counties in the northeastern, I'm not saying that is true, no. But if you go to the world, you have found several cases of stillbirth. Secondly, air pollution is associated with postpartum depression. These are places where, just as an example. And thirdly, obviously, things like storms and adverse weather are associated with, depression and the rest of the thing. So I hope that people have gotten some idea what. Let me adjourn here, and maybe you arrange sometimes I talk to the youngsters in more detail. The slides are all with I hope people will be able to follow the slides, but they are with you there. Thank you. Yep. Oh, I'm allowed to take questions or clarifications. Some burning question clarification. Yes, yes.
For the eminent professor.
I also want questions from the undergraduates. Otherwise, I'll ask Dr. Luca to come here and we can give that. Okay. Yes.
So my first question is the tax revenue in Kenya sufficient to fund healthcare? If it is, what efforts are being made to increase allocation for healthcare? And then, secondly, okay, I saw somewhere that the government intends to reduce the budget for health by 67 billion. What informed that decision? Thank you.
Let me start with the second one. The second one, I don't know because I'm just a lecturer. I don't know what happens in the government. But it's a wrong decision. I gave you the figures, isn't it? Even by GDP, we are at 1.2 or 1.8. Abuja Declaration, it is insufficient. So the second one you say is the tax. The thing is, the problem with health in Kenya has got nothing to do with tax. Absolutely nothing. In fact, don't waste your time discussing tax. The problem with health in Kenya is inefficient use of available resources. If you can address that, then you can now go. You see, we jump onto the other side of the coin of tax. No. Who knew we would have a lot of money before devolution? There's a lot of money. You can actually do your calculation. There's a lot of money. And it's estimated, even for Kenya, every year we waste about 40% of the allocated budget through inefficiency. Stealing is included there as a polite word. I want to use this inefficient. Yes. In fact, if you could deal with those, you would be surprised what will be released before you start talking of tax. That's why I say health is so complex. The people, the primary leaders of health need to be people who actually understand the complexities and have got the competency to do that. Otherwise, if you have, so they are leaders, let me tell you, and they are office occupiers. I'll leave you to judge one. In Kenya, do we have office occupiers or leaders? And if, look, so let me help you to understand. Who is a leader? A leader is someone who is given stewardship over 4 assets: people, capital, processes, and information. Your job description is to add value. The problem in Kenya is that we have office occupiers. They don't qualify as leaders according to that simple definition. We just say it. It's nothing reasonable. We have office occupiers and we need leaders. Because the thing is complex. Good, you can come from irrigation and go to Ministry of Health. I think we don't see what you offer there. This thing is complex, the way I've done there. Sorry, I'm not sharing much.
Can I?
Sorry. They say diaspora are not hearing us. Eh? Yeah. He's saying it's burning. It's luckily it's white smoke. Eh?
No, actually, Prof, let me ask you one question.
I don't
How are you?
Yeah, ask me. Yeah. We can answer.
Sorry, mine actually is I'm trying to say the role of the pharmacist. You talk about the systems are inefficient.
Yeah.
And in the Western, they've tried to demonstrate the value of the pharmacist.
Yeah.
And there are some very big studies. Now, going back to where you come from, Strathmore University, is there any chance that we could get some grant to demonstrate the value of the pharmacist so that we could also play a role in the SHA and the SHE? That's what I've been fighting for.
Prof,
Thank you.
3/4 of my students in Strathmore, the people are actually pharmacists. So they are there. Now, I want to answer it robustly. And it's good you put it. People say the pharmacist, 3/4 of any health budget is consumed by 2 activities: salaries and medicine. So, yes, it's salaries and go and do something. Salaries and medicine. So the role of pharmacists, so if you had 2 people, one of them should be a pharmacist. Yeah. So an HR person and a pharmacist, 3/4, because that's the critical. That's the critical thing. There is no health without medicine. It's as simple as that. So let's not even debate that one. What we say that when can that role be actualized?
That's what I'm asking.
Yeah.
Thank you.
Exactly. He's our boss.
No. I left long time. 7 years, I'm not your boss. A very good presentation. In my opinion, you see, I always tell people, apart from God's power is the number one most powerful. The second one is political power. And I don't know, many have, I always tell people like that, they are not sure, but it's true.
Yeah.
So instead of having two sides of the coin, can we have a three-sided coin? Then you insert political environment. Because all those things seems to be, even with the questions coming.
No.
Yeah.
Politicals, you probably, Dr. You got it. When I said stewardship, that's where it comes in. So it is stewardship that needs to do that one. But I agree with you. All health decisions are political at the end of the day. Yeah, you will not. From approval, they will be political. What we should be doing, Dr. is that how do we become savvy in engagement with a politician? We have to do that. We have to do that. How do we come savvy? All decisions are political. Whether it's putting up infrastructure, whether it's starting another school of pharmacy, at the end of the day, it is political. That's the structure of the government we have. So the best thing, how do we find our way there? And there are several ways you need to do. Yeah. Identify where the fiercest political opposition comes and concentrate your energy there. Yeah. Once you get done, then it is okay, because it will be reversed if you don't get it. And part of the things we teach at Strathmore is actually just doing that. You need to do, it's not political, stakeholder engagement. So once you do that, and it should be a compulsory one. So communication and stakeholder engagement is very important. So you now categorize them. Who are these ones? It's so critical, Prof. So critical. Yeah. Most of this may not be a standalone. You can say soft skills that people get maybe during internship. So internship is not that kind of thing. You arrange seminars where we give them pro bono. These are people that they don't have to pay. I can come and give them those skills pro bono, but soft skills. Yeah. Yes. Diaspora. I've answered. Okay. Yes, we can search for diaspora. It's democracy.
Yes. You have done well, Professor. I think we have to arrange. Professor Kalebo, you are here today and you are the leader of the external lecturers coming to give. What were you calling that program? Mentorship talks to students and staff. I think, Professor Kalebo, from today, we want that date set for Prof. Kokwaro to come to the school, and we can even invite the wider alumni for his audience. Yes, Dr. Wanyanga will escort him. Because this is very, very critical for us to get this information. And as you've heard, without medicines, there is no health. Yeah? And Dr. Mwenda, you are there. Supply chain. As long as pharmacists, we have not gotten it right that we have medicines available in the hospitals, that we are in charge of the supply chain for medicines, we haven't gotten it. So we shall be looking for you, Prof. Kokwaro.